Good afternoon. I'm happy to be here with Professor Faiez Zannad, and I would like firstly to thank you for being here this year at Giornate Cardiologiche Torinesi. And I would like to ask you a couple of questions about your talks you gave us today. The first one is about SGLT2 inhibitors, and knowing nowadays the proven benefit across this broad spectrum of heart failure with preserved, reduced ejection fraction, and also in patients with chronic kidney disease. In which patient do you think today we should still be cautious before prescribing? And I'm asking you both in the acute and the chronic setting, so ambulatory, hospitalized and ambulatory patients.
Yes, well, everything we know about SGLT2 comes from clinical trials, more than 90,000 patients in trials. And therefore, there is a very large variety of patients who have been enrolled in this trial. Only 2-3 categories. Pregnant women, but this is common to all new medications. Insulin-dependent diabetes, type 1 diabetes. There may be subsequently some development in this area, but for the time being, there is an increased risk of ketoacidosis. And therefore, this is a caution, and we'd rather abstain from using this drug. We may still use the SGLT2 inhibitor in patient necessitating insulin, but not type 1, right? And even in patients necessitating insulin, you need to be cautious about the enhanced risk of ketoacidosis. Now, the third condition is patient with the real low eGFR. Exceptionally, actually, for class of drug, most trials have enrolled patients with really low eGFR, low down to 20, 25. But below 20-25 CKD class 4 and 5, and especially in hemodialysis, we have no evidence. There is no reason to believe that the drug would be unsafe, but we have no evidence. So these are the categories where we may still need to wait.
Thank you. And another quick comment on finerenone. It's just been published, the Fine Arts HF last month, and I would like to ask you if you think that these drugs will play an important role in patients with heart failure with preserved ejection fraction, and also in patients with heart failure and chronic kidney disease together with SGLT2 inhibitors.
Absolutely. This is a very important class. Well, actually, mineral receptor antagonists in general, MRAs, whether steroidal or non-steroidal, but the accumulated evidence with all this class is overwhelming in heart failure, in post-MI, now in diabetes kidney disease, and in HFpEF as well. Well, there are subtle differences, and certainly the evidence in CKD with diabetes is only with finerenone. We have no evidence with spironolactone, and they may not replicate the result because the kidney safety is not the same. But certainly over the board, this class now is actually coming close to the SGLT2 inhibitor because they are effective in heart failure, in post-MI, heart failure with reduced and preserved ejection fraction, and in diabetes kidney disease. But the diabetes kidney disease is really finerenone. We have no evidence with spironolactone. So, and the good news is that if you combine both SGLT2 inhibitors and finerenone, then you enhance the benefits. So that's really good news for nephrologists and for the cardiometrists at once.
Thank you very much for your talks today, for this small talk today, and we're looking forward to see you next year.
Thank you for having me. Wonderful.